when you evaluate a drug, you have to know exactly the population that you focus on. So staging is very important. And there is, I would say, a big mess in the staging of melanoma for different reasons. The first is that the AJCC classification, which is used over the world, is changing very frequently. So this is a very difficult task to compare. For instance, adjuvant trials which have been conducted 3 years before and 3 years after, because the AJCC has changed. And so you have to transform in your head, well, this group was in fact in this group, and so on. So at the end, the interpretation is quite difficult. And there will be now another difficulty, which is due to the results of 2 studies showing that after a positive sentinel node, there is no benefit to extend the surgery to the other nodes. No benefit on the overall survival. So that means that in the community now, when patient will have a sentinel node, most of the doctors will not propose to complete surgery. So many patients were in fact considered as 3B, were 3A, when they had the first step of the sentinel node, and then when they complete surgery, they came to 3B, for instance. So the consequence of that is that in the next years, there will be a downgrading of patients. That means that many 3B patients will become 3A. And then the interpretation of the therapeutic trials in the old 3A population, old 3B population will be completely in trouble, because it will be impossible to compare the results. And it's very important to compare the results, of course, because we always always comparing the results of a drug, and the trials are not done at the same time with the same AJCC, with the same way of staging patients. So at the end, it's tricky.
I don't see any improvement in the new AJCC classification, only confusion.
The conflicting data with the new AJCC classification and the problem that have been mentioned by Dr. Grob regarding the change in AJCC classification reflects in some part the fact that the role of local treatment is declining over time, and the role of systemic treatment is rising, and because we have more effective treatment, more effective strategies, but and it's something that we learned with other tumors such as breast cancer, so limiting the surgery and also the treatment of regional lymph nodes because of effective treatments. Something like this is going to happen also in the melanoma world, but we have to remember that no systemic treatment can cover a bad surgery and a bad local treatment. So the integration of local treatments and systemic treatments is the optimal strategy to give the best treatment for a patient with melanoma. So I think that the AJCC have been released this year. We have time to learn more until the next year, and in the meantime we have to navigate with the new system and to learn more and to implement within multidisciplinary groups local treatment and systemic treatment, but we are confident that we can overcome all these problems because we now have very effective strategies. So there is hope for patients with melanoma.